The guidelines want to be extremely practical, friendly, clinically oriented. The Brady part of the document, I think that the most important is the new classification of Brady indication in two categories based on the electrocardiographic initial presentation of the patient. As regards cardiac resynchronization therapy, a lot of randomized trials have been published in this recent year, and we could merge the result of this trial in precise recommendation.
The atrial fibrillation ablation registry is a registry about what is happening in Europe relating to the ablation of atrial fibrillation. 80% of the procedures are first procedures and 20% are redo procedures. Also, though, we are looking at about 4% of the patients are having some cardiovascular complications. So in general, I would say that we do have a lot of centers in Europe performing the procedure, that they are performing that safely. We still cannot say that they are performing it effectively, at least for the long term. We know from the pilot study that about 75% of the patients are what we can call cured from atrial fibrillation 1 year later.
Personalized management of atrial fibrillation is a vision that we want to achieve in the next decade. The basis for achieving that is to apply guideline-conform and evidence-based interventions. The next step will be to identify the individual causes of atrial fibrillation in a given patient, and once we have identified them, classify patients accordingly and design targeted interventions at these causes. If we do that on top of what we currently have in terms of evidence, we will be able to reduce the devastating consequences of atrial fibrillation further in the next decade.
Nations may rise and fall, but an idea lives on.
So antiarrhythmic drugs remain very important therapies, but they are not in themselves sufficient to manage patients with underlying significant cardiovascular disease. In the future, we will see many new antiarrhythmic drugs. We haven't found a really good one yet, but the search continues, and we're looking for one that will not only be safe, but also effective.
Special considerations in my choice for electrical or pharmacological cardioversion are, let us say, the background of the atrial fibrillation and the way the patient presents. A chemical or pharmacological cardioversion is preferred when you see that the patient is unstable from the electrical point of view. The predictors of success have been extensively analyzed in a recent survey of the European Heart Rhythm Association. And a large atrial size is a predictor of failure. High age is a predictor of failure. And continuation of antiarrhythmic drugs after the cardioversion is a predictor of success.
Electra Registry is a new registry. It is the first European registry on transvenous lead extraction procedure. There are 20 countries that are enrolling patients, and now we collected 1,445 patients. We noted the changement in the indication. We considered in the past 70% of indication for infection and 30% for lead problems not infective. Now the registry tells us that 52% are for infective indications and 47.5% for non-infection. And this is a very good news.
ESC Congress 365 is your free access to ESC Congress content all year long.